So just think about those things. Bad combinations, also combinations to always avoid: ACE and ARB at the same time. If you see a doctor doing that, that doctor has not grabbed a book in 10 years now. No, that was actually the on-target trial was published in 2009. So going into 8 years now. That combination was found to be harmful, with worsening renal failure, increasing incidence of syncope, and the only thing that helped was the proteinuria. But why are you going to reduce the proteinuria if your kidneys are going to fail more frequently anyway? So it's a bad combination. You still see doctors doing that stuff. That doctor is completely ignorant about the most recent evidence. That was a bad combination, like the one I mentioned with the clonidine beta blockers and calcium channel blockers. Never stop abruptly, beta blockers and clonidine. Then we have other stuff that are less commonly used. Minoxidil it's a very potent arterial vasodilator. When you see a patient on minoxidil, you already know that you're dealing with bad hypertension, or with a patient with severe multiple allergies. I guarantee you that if you explore it, if you get into detail, it's either an anxiety issue or it's a doctors that are very quickly to write off medications. Don't be one of those doctors, because you need to teach your patients that you need to be on these medicines instead of being on these medicines. Imagine like you prescribing alpha-methyl-dopa, minoxidil, and all that stuff. It's not good. And we have reserpine. I've never prescribed that. It's a centrally acting antihypertensive medicine. We already talked about the nitrates, beta blockers, calcium channel blockers. Yeah, that's pretty much it, I think. Yeah, so and then how do you manage, just to cover into dialysis, is how do you manage patients with dialysis and severe hypertension? So the first thing you should do is call the nephrologist. And the reason being is that dialysis patients are very volume sensitive. So if you do a physical exam on somebody who's dialysis dependent and hypertensive, you may not encounter the classical findings of volume overload, like what you're used to seeing as volume overload, like a lipedema, crackles. Dialysis patients may not have that, but something as little as 500 mLs or half a kilogram can make a whole world of a difference in terms of blood pressure control. So the first thing that we should always do is lower the weight. Second thing that we should always do is lower the weight. The third thing is lower the weight. And then when you already are sure that the patient cannot tolerate more reduction in the weight, then you start playing with the medicines. But it's always a weight issue. It's always like you have a little bit more. Just so you understand, because if you have a dialysis patient, I want you to do the exercise so you understand how to interview a dialysis patient. Dialysis patients, they always have a dry weight. Have you guys heard about the dry weight? So the dry weight is, your water weight and your solid weight. The weight that you gain between Monday and Wednesday, if you're Monday, Wednesday, Friday dialysis, you gain 2 kilograms, that's water weight. Or when you're new to dialysis, you have a lot of water weight, and little by little, we start removing 1 liter, 2 liters, 3 liters, and we tell the patients, don't drink a lot. And finally, we're able to determine what your dry weight is. We do that by physical exam, looking edema, looking at crackles, and looking at the normalization of the blood pressure. That's your dry weight. That's a very dynamic thing, because you can imagine if you eat more, you gain weight. If you eat less, you lose weight. So if you remember my fingers, you're gonna understand this dynamic. If your weight is going up, your blood pressure is gonna go down unless we correct that. You understand what I'm saying? Let me give you the other way and see if you get it. If your weight is going down and I don't correct the estimated dry weight in the computer on the machine, your blood pressure is going to be very high because I'm leaving extra fluid in your system. Did you guys understand what I'm saying?
I think so.
Okay, so always remember, like if I'm losing solid weight and I don't change my weight in the machine, that's going to translate into hypertension. More water, you can't see that water, but you guide your decisions based on blood pressure, and you need to educate the patients about that. I always tell them from day one, if you're losing weight, you're gonna have higher blood pressure and we need to lower it. You need to let me know. Because it's a very dynamic thing. I educate my patients and I tell them, like, please let me know if it's high. So that way we can make the changes real time. Sometimes we drop the ball, nobody's paying attention to it, and the patients, they start losing solid weight. They don't change the weight, and the patients end up getting admitted to a hospital with congestive heart failure. It's a very dynamic thing. Okay. And that changes a lot in the holidays. I'm always like changing, increasing weights. After the holidays, I'm reducing weights. In the summer, the same thing. So you have to think about those variables when you're dealing with hypertension, specifically in the dialysis population. And the key message is it's a volume issue. It's not a prescription medication issue. If I know for a fact that this patient cannot tolerate more reductions in the weight because he's already having cramps or completely intolerant, you have no choice. You have two choices actually. You can either increase dialysis time, which is effective, very effective, but these guys, they're already very reluctant to increase the time in the machine. They're already miserable sitting there for 4 hours. Who's going to want to increase the time? Mm-hmm. Most patients get anywhere from 3.5 to 4 hours. So you can go by 15 minutes increments, but I'll tell you that most patients are resistant to that idea. Mm-hmm. And then you're left with the option of doing medication adjustments. In dialysis patients, we stay away from thiazide diuretics. They don't work. We stay away from, if they're not urinating, we stay away from any type of diuretic, period. And we usually try to give beta blockers and calcium channel blockers, like nifedipine is very effective. If they still urinate, we prescribe ACE-ARB because we want to continue to preserve the residual kidney function. That's a very, very important concept for you when you're doing your urgent care ER work. You see a dialysis patient, and the first question you need to ask is, do you still urinate? If the patient tells you, yes, I still urinate, make every possible effort not to prescribe something that can potentially harm the kidneys, including contrast studies, unless you absolutely have to. Let's say that you have no choice. You need to know whether or not this guy is bleeding or whether or not this guy has an abscess in the abdomen and have to give contrast. Mm-hmm. So in that case, you have to. But if you can do every possible effort to preserve the residual kidney function, you're helping your patient. Because the studies have consistently shown that it's not the dose of dialysis that makes a difference. It's actually the preservation of residual kidney function what really makes a difference in terms of survival and quality of life and phosphorus control and everything else. Okay? Let me think what else. What else can you guys think of? Or if you have questions, I mean...
Like, when you have crisis hypertension, like super high blood pressure, like 200s, then you have this different class of medications you can use?
Right, so you're getting into the arena of hypertensive emergency versus a hypertensive urgency. Mm-hmm. So definition of hypertensive urgency, there's really no number that makes it a urgency or emergency. It's just the presence of an end organ damage. And the end organ damage can be an acute hypertensive retinopathy, it can be an acute intracranial hemorrhage, it can be an acute ischemic CVA, it can be a dissecting aortic aneurysm, or it can be like hematuria. So, and for those patients, there's a very clear distinction, and you're going to be asked this question on the board, so I'm glad that you brought it up. If you have a patient with chronic hypertension, there is no rush to normalize blood pressure. And I try to teach this to all my students, fellows. You have to start slowly, gradually. Because if you give a bunch of medicines, this patient is going to bottom out, he's going to pass out, or he's going to hate you for giving you all these nasty side effects, and they're going to run away and they're not going to get it treated. So that's the first concept. And this happens a lot in the wards when you guys are working on the wards. A lot of the doctors get very excited, like, oh, nifedipine 30. The second day, oh, still high, go to 60. Third day, oh, go to 90. Don't do that. There's no need to do that. You're hurting the patient, because if you remember pharmacology, you need 5 half-lives for a medication to be really fully like absorbed and full therapeutic effect in your system. And the wards were experts on aggressively treating hypertension for no reason. There's no reason for doing that. And then the next thing that you have there is like, oh, the creatinine bumped to 1.7, call nephrology. Duh, it's hemodynamically mediated. You just drop the renal perfusion by aggressively treating hypertension. And I cannot tell you how many times I get called about this type of consults from doctors aggressively correcting asymptomatic hypertension. So that's one concept that I want you to memorize. The second concept is that there are different goals depending on the pathology. And you need to know this by heart because you're gonna get asked this question on your boards. If you have an acute ischemic stroke, you wanna reduce the blood pressure by 20% only. We call that permissive hypertension. And that's been shown in many studies that patients with an acute ischemic stroke that are overcorrected, they have bad outcomes. So you want to allow permissive hypertension. In the other hand, if you have a patient with an intracranial bleed, or if you have a patient with a dissecting aortic aneurysm, that needs to be normalized right away. And do you guys know which medicine do we use? Let's say for a dissecting aortic aneurysm, what is the drug of choice? IV beta blockers, like esmolol or labetalol. That's a medical emergency. You need to correct them right away. Same thing with you have an intracranial bleed. So always remember that because they're gonna trick you. They're gonna give you a ischemic stroke. You already know, like, okay, wait. I have to allow permissive hypertension in the first 24 hours. Okay? Always remember that. And in clinic, there's no reason to normalize the blood pressure aggressively. Just give them, my practice, I know everybody is different, but my practice, I prescribe a medicine and I bring them in 2 weeks. Why? Because I want to leave the possibility of a medication circulating in the blood before you jump and start increasing the dosages. And a lot of the times, patients, nobody likes to take medication. I haven't met the first one, unless you're a hypochondriac. Nobody likes to take medication, so you get more adherence to your patients and more like growing your practice. If you're prescribing, if you explain the reason why you do what you do, and if you do it in a slow fashion rather than like changing multiple things at the same time. Okay. Let me think, what else? Can you guys think of anything, any questions?
Do you ever use like nitroprusside?
Only in those scenarios, in the ICU. Like patient with hypertensive emergency with CHF is a good medication. You cannot use it for a long time because one of the metabolites can convert into cyanide. Especially in advanced kidney disease, we don't recommend that you use nitroprusside, but it's a very effective medication, very effective. I've used it several times. And not every pharmacy has it because it needs a special preparation. Apparently with UV light, it can actually degrade into ineffective medication. So it's a little tricky. Not every hospital pharmacy has it. And you cannot get it like this. Like if I need esmolol, like right now, my pharmacist can get it for me within minutes. If I need nitroprusside, it requires like a little more elaboration. Mm-hmm. But another thing that what we do is like a nitro drip. That one is also readily available. And the nice thing about nitro drips is that it's so easy to titrate. In other words, if you have a CVA and you want to do permissive hypertension, you can play with it, shut it off, turn it on. And it's very short acting. So that's a nice thing about that medicine. When you're doing your ICU rotation, you're going to be doing a lot of that. All right. Questions? Too much information. I'm sorry, guys. You're probably tired.
It's a lot and it's fast.
It's a lot of information, but you need to be comfortable with your hypertension management.
No, that's good.
Yeah, and think about like always the ABCs. If I can leave you a concept to take home is think about pseudo-resistance. Pseudo-resistance is very common. You can fix that by good counseling, the ABCs, medication adherence. Most people are primary hypertension. For those that are not, you already know more or less who to order a secondary hypertension workup. You already know the definition of resistant hypertension. You already know that spironolactone is the fourth drug. You already know that bad combinations or things to stay away from, and not to order imaging. Like, you need to always have biochemical evidence of something before you jump and order imaging, otherwise you're gonna get it wrong. And yeah, it's not hard. Like I always tell my students, hypertension medicine is not rocket science. It's just like have a very consistent approach to talk to the patients, to provide a lot of education, because if you start writing off your options, what are you gonna do? If you start like adding everything as an allergy, just really think about it. And another thing is like negating ACE/ARB to patients with kidney or heart disease is a disservice to this population. You have to offer it to them. And you have to have your level of comfort, and you have to document the reason why you do what you do, and educate the patients about potassium. We learn also about potassium. That's another important thing. Okay, and thiazide-induced hyponatremia, you're gonna see this a lot. It's common. Okay. Questions? All right. Thank you so much. So I think we'll do the clinical cases tomorrow because it's already late. I have like a couple of nephrology cases, and maybe tomorrow we can do this really quick in 1 hour.
Okay.
And we can dedicate the other hour, maybe talk about rheum or ID or derm, whatever.
Yeah.
We'll talk about different things, useful things. I want to give you useful information, like board-oriented information. Okay? There we go. All right, guys.